Welcome to our first episode of Ironwood Cancer Insights. My name is Kayla with Ironwood Cancer and Research Centers, and today I am joined by Dr. Farooqui.
Thanks for having me.
Of course, yeah, thank you for being here. April is Head and Neck Cancer Awareness Month, and Dr. Farooqui is a specialist in head and neck cancer ever since we specialized back in June as a private practice.
Yeah, so back in June, our group decided that we would all kind of siphon off different cancer types, and that would become our focus. And I'm specifically going to be doing head and neck cancer. And the subspecialization has been great because it kind of allows us each to kind of really focus in and dive deep into the literature and kind of all the new evidence and the new technologies for each cancer type. So I've been doing head and neck cancer, so I'm excited to talk about it today.
Yeah, that was awesome. And I've also heard that it is great for patient care as well. The patients are loving it.
Definitely, yes.
April is Head and Neck Cancer Awareness Month, and it's a great time to raise awareness about this cancer. Can you just explain a little bit like what head and neck cancer is?
Yeah, definitely. And so basically, head and neck cancer is any cancer that's really located in the head and neck region. I know that's kind of broad, so the way that we break head and neck cancer down is kind of by compartments. So the way I kind of think about it is that there are 5 main areas of the head and neck. And so we're essentially talking about like behind the face, kind of deep down in the throat. So it kind of starts at the bottom. You have an area called the hypopharynx.
Okay.
So that's kind of the bottom of the throat, and that's where your voice box is near. On that note, you have another area called the larynx. That's where your vocal cords are, your voice box. Right above that, you have your oropharynx. That's going to be where your tonsils are, the base of your tongue. So it's kind of in the back of your mouth.
Okay.
Then you have the oral cavity. So that's going to be, the tongue, the walls of the mouth, the roof of the mouth. Right above that, then you have the nasopharynx. So the nasopharynx is the region that sits right behind the nose, kind of where your sinus cavities are. And so really head and neck cancer is any cancer that fits in some of those compartments. There are some other types of head and neck cancers like salivary gland, and other cancers can be in the head and neck like lymphomas. But for our purposes, we usually talk about a very specific kind. Usually the most common types of head and neck cancer is considered a tumor type called squamous cell carcinoma. That comes up a lot with patients. They want to know what kind of cancer they have. So squamous cells are actually normal cells in the body that tend to line the epithelium. So epithelium is basically the lining of different parts of the body, namely kind of like your GI tract, your respiratory tract, so your mouth, your lungs, your esophagus. So generally, any tumors that come up in those areas can be what we call squamous cell carcinoma. So most head and neck cancers are squamous cell. Some lung cancers are, some esophageal cancers are, some anal cancers are. But generally, when you hear squamous cell carcinoma, you're kind of thinking of cancers that are in the lining of an organ or part of the body. And that's generally what head and neck cancers are.
So what are the most common things that patients are complaining about when they come see you?
Yeah, that's a great question. So basically, there's a lot of different symptoms that can happen with head and neck cancer. And as I mentioned, a lot of it depends on which compartment the tumor or the cancer is. So for example, I have some people who come in because they've had voice issues. Their voice was hoarse, or they've just lost their voice, or it just sounds different. And that kind of cues us in that maybe there's a tumor kind of lower near where the larynx is. Or sometimes people have trouble swallowing. Suddenly they're eating breads or hard foods, and suddenly they can't. That might be a cancer that's maybe deeper in the back of the throat or in the mouth. Sometimes just pain, mouth pain, mouth sores. I've had some people who've come in with some blood in the mouth. So there's a variety of those types of symptoms that happen. Usually, any kind of swallowing, neck pain, neck swelling, those are some of the most common reasons. Sometimes people can get lymph node enlargement, which can be a sign of cancer, so they'll get swelling on the external part of the neck. So that's another thing that gets caught, because sometimes they can physically see that there's a mass or a swelling there that they suddenly didn't notice. So sometimes they may have some, recurrent runny noses or a really stuffy nose, and then they end up seeing an ENT, and those tend to be the most common pathways that people end up coming to our clinic.
So after somebody is having symptoms, what happens next? What are the next steps?
Yeah, so it's a really good question too. So that kind of leads into how do the patients make it to our office? Because if you think about it, most of the time we're seeing people who actually have a diagnosis of cancer. Sometimes we see people just for the symptom part, but more than likely they'll end up seeing their primary care doctor, whether it's like maybe some sinus issues or some pain. They may get some antibiotics, or they may get some pain medicines. and then eventually they may end up seeing like an ENT, an ear, nose, throat specialist. That's different from what we do. Those are doctors who are specifically trained in the ear, nose, throat region, and they do surgeries and procedures. So a lot of the cases end up seeing an ENT doctor, and they will sometimes do a procedure where they take a camera and they go check out any concerning symptoms. So if a patient's having a problem with their voice, they'll take a camera, they'll kind of take it down, look at the larynx. If they're having some nasal issues, they'll look up at the nasal turbinates, or they'll look up in the nasopharynx. And sometimes they're the ones that really catch these masses or these tumors. And then they'll sometimes do a biopsy. Other ways people get caught with this issue is sometimes they'll see a dentist, and the dentist will notice something in the mouth or in the tongue, and then they'll eventually refer to ENT or to us. And those are kind of like usually the ways that those are the stops that they usually take before they come to our office. And then sometimes they'll come in with a biopsy where they've had tissue sampled by one of the surgeons or the dentist, and it will actually show cancer cells. Other times they'll come to us before that point so we can kind of help figure out what the next step would be if we wanted to get some kind of tissue.
So for head and neck cancer, what are some of the treatment options and how do you approach treatment?
Yeah, so basically treatment, I think the first thing to know about treatment for most cancers, but especially for head and neck, is that it's very much a team-based approach. So what I mean by that is you want a team of doctors that have a good amount of experience, who communicate well, and who can kind of come together and create a good plan for that individualized patient. So usually it all starts with having a really good ENT doctor, and by that I mean a good surgeon who deals with head and neck disease and head and neck cancers. From there, sometimes you'll get a medical oncologist involved. That's like myself. We're the doctors who do treatments like chemotherapy or immunotherapy and some of the newer agents out there. And then the third piece of the puzzle is usually a radiation oncologist. So that's a doctor who treats cancer primarily with radiation. And usually you want, most cases, all three involved, and you want them all kind of on the same page and making sure that everybody is comfortable with the plan. And so that's very important. Usually, a lot of times these cases get a first look at with the ENT. And the decision becomes, can we operate on this tumor or not? As you can imagine, it's a very tight area that we're dealing with. The oropharynx, the nasopharynx, the hypopharynx, it's a very small area. There are a lot of important structures in that area. So if there's a tumor in there, we need to know if the surgeons can safely remove it. And if they were to remove it, we want to know that they can take out as much tumor or all the tumor if possible. If they don't feel like that's possible, because maybe the tumor is near an artery or a nerve that makes it very high risk that they can't remove it all, or if they feel like the surgery will be too dangerous, that's sometimes where we'll say, you know what, maybe we're going to be better off doing a different approach like chemotherapy or radiation. Sometimes though, even if they get surgery, we'll still have to do those treatments. So again, we usually like to have everybody on the same page and kind of let the ENT dictate that decision.
Okay, so that's really good to know. So if a patient needs more care, that's determined by the surgeon, and they come to Ironwood, what does that look like?
Yeah, so basically if it's determined that the patient needs something more than surgery, whether they had surgery and they need something additional, or if they can't get surgery and they need full care, usually they'll come see us, and they'll either see myself or one of the other radiation doctors, and from there we'll kind of come up with a treatment plan. So usually what we would do is we would have one of the doctors see the patient. We would kind of go through their history, review their case, their imaging studies and all that, and then generally we would decide, do they need radiation, do they need chemotherapy, or do they need both? I'm a doctor who gives chemotherapy and immunotherapy and things like that, so if they would need radiation, if they were to see me first, I would just have them see one of our radiation doctors that same day. Fortunately, in our office, we have our radiation doctors down the hallway. So essentially, if they see me, I usually will communicate to the other doctors that this patient needs to be seen. We'll tend to walk them over, and they'll have like an additional visit with the radiation team too, or vice versa if they see radiation first. And then the two of us will kind of communicate and come up with a plan. But in most head and neck cases, many of the times we're actually doing what we call chemoradiation, where we're doing chemotherapy and radiation together. So the idea there being that we are trying to attack the cancer from two angles, one with chemotherapy, one with radiation, because we have countless studies saying that combining the two is especially effective. because each treatment approach makes the other stronger. So usually they'd be looking at doing chemoradiation depending on their surgery plan and depending on how fit they are. The other important thing to know is that we really want to tailor our treatment to the individual patient. So that means we take into account their age, their other medical issues, their own feelings and hesitations and concerns about treatment. Some people that are maybe a little bit elderly, they're very hesitant about chemotherapy, so we want to be cognizant of that. So we really want to individualize their treatment plan because then they have the best possible outcome.
So it's awesome. It sounds like patients can really get a comprehensive approach when they visit Ironwood. And with oncology nowadays, things are evolving so fast, and especially with head and neck cancer. Can you talk about that?
Yeah, so in regards to the comprehensive approach, part of the right answer to that question is actually with research. And so fortunately we have some clinical trials open and we have a research department. So we're always looking at different new agents, novel therapies that we can use on patients. We currently have a few head and neck cancer trials, both for newly diagnosed patients who are starting treatment, as well as for patients who have relapsed, which means that we treated their cancer and unfortunately it has returned. So that's another great and exciting part of being in the field, especially in this day and age, because we're probably in a time where the most amount of oncology drug approvals have happened in the last 5 years. And so we're hoping that continues, and we're fortunate to have our own trials that we can kind of stay on the cutting edge, and we're always looking to accrue more. So that's another nice additional treatment we can offer patients if they're eligible.
Yeah, so if patients are wanting to be involved in clinical trials and they have head and neck cancer, do you guys talk to those patients about that, or how does somebody get involved in clinical trials?
Yeah, it's a really good question. So we have a research team, and a lot of times the research team will be reviewing new patients and patients who are on treatment to determine who is eligible or not. It's also on the part of the doctors to kind of be looking at the different trials that are out there and which patients may or may not be a candidate, and also have the foresight to kind of try to think ahead if a trial may be a good for the patient. Mm-hmm. But usually our team would kind of look into that, and we would essentially have a meeting with them to try to enroll them in the trial, make sure they're eligible. There's usually different types of tests and other procedures you have to do to get onto a trial, so we would have to just carry all those out, and if all of those check boxes are marked, usually they would get enrolled. The other thing that I think is really important being in Phoenix is that we have other great research centers too. So at the end of the day, it all comes down to what's best for the patient. So the other thing that we're trying to be in tune with is what other trials other facilities have, because if there's a great trial across the street, we still want our patient to have access to that. So that's a big part of that team approach and making sure that we're all working together to get the best possible outcome.
So Dr. Farooqui, I'm sure you get a ton of questions from your new patients. And one common misconception nowadays is that smoking is what causes cancer for head and neck. Are there other ways that people can get head and neck cancer, not just through smoking?
Yeah, that's a great question, and I think it is a misconception where people think that's the only way to get it. I would say it's definitely probably a more common way. So smoking and tobacco use has always been tied to head and neck cancer, just like it is with lung cancer. All of that is kind of the same, aerosolized tract in the body. But definitely in the last, I would say 10 years, we've been seeing a lot more HPV or human papillomavirus-driven cancer. So I think it's especially important to raise awareness about that, because you have some non-smokers who get symptoms and they may write it off because they're a non-smoker. You don't think about cancer, not to create any unnecessary fear, but there are HPV-driven tumors that can also arise in non-smokers. Nowadays, a lot of our younger populations are getting the HPV vaccine. It used to be predominantly for women in regards to cervical cancer prevention, but now actually young males can also get HPV vaccines, and we actually are finding that hopefully that will reduce rates for both males and females for head and neck cancer too. So the HPV vaccine is definitely something that we're hoping will cut down rates as the generations progress. The other thing is alcohol. Alcohol can definitely kind of increase rates of head and neck cancer. So again, we always try to tell people to abstain or to drink in moderation. And then any kind of radiation, injuries, traumas, things like that to the neck, which are uncommon. Those are other things that can cause cancer in that area as well.
So if somebody does have HPV or they are a smoker, is there some type of screening that they should be doing or seeing their PCP more often?
Yeah, again, great question. There's not really any great screening for head and neck cancer. Now, for smokers and lung cancer, there's great guidelines on lung imaging to be done every year. But with head and neck cancer, there's no great screening test. I think by just paying attention to your symptoms, making sure you're seeing your dentist regularly, because some cancers we've seen have been caught by dentists or oral surgeons, and then just making sure that you're in close connection with your primary care doctor and can communicate changes to them. I think those are the best ways to kind of look out for cancer and try to prevent it, so to speak. And then obviously to cut down on smoking, alcohol, any of those types of things that can increase risk.
Right. So earlier you talked about some of the treatment options that are available as far as chemo, radiation. What does treatment look like for patients?
Yeah, so I will say that I think that head and neck cancer treatment, especially chemoradiation, it's definitely a very tough course. So not to sugarcoat it, it can be very challenging. It's generally about 6 to 7 weeks of treatment. We're usually giving chemotherapy and radiation together. Radiation is usually every day, so it is fairly extensive. It's usually a few minutes every day, but it's a Monday through Friday treatment. Chemotherapy tends to be once a week, sometime every few weeks. But it definitely can be taxing because with the location that the disease is, swallowing, throat pain, those types of things can actually get a little bit worse before they get better. So whenever we have a new head and neck cancer patient, we always usually try to connect them with a nutritionist. We pay close attention to their weight. We make sure they're not getting too malnourished or that they're keeping enough calories so that they can stay well enough to get through the treatment. We're giving them extra fluids, we're well hydrating them. So really giving them good supportive care is the way to get them through. And we always tell people it's definitely a marathon, not a sprint. So it's just kind of taking it one day at a time, one treatment at a time. And before we know it, the treatment will be done. And then, a few months later, they've recovered. And we generally get very good outcomes. So we always try to have our patients keep their eyes on the prize because, for very short-term pain and suffering, there's a lot of long-term gain to be had. So I think we just have to keep reminding our patients of that. And we have great nurses, we have a great nutritionist, and they're always coaching our patients. They're always trying to support them through it. And I think that's a great way to get people to the end.
Yeah, and it sounds like the earlier you catch it, the outcome might be a little bit better. So maybe making sure that you are seeing your PCP.
Exactly, yes.
Thank you for being here, Dr. Farooqui, especially during Head and Neck Cancer Awareness Month. I think it's really great for our patients and for all of our listeners out there.
Yeah, no, thanks for having me. I'm just glad that we got to raise some more awareness for the disease.
Of course. And if you do want to see Dr. Farooqui, he does accept new patients at our Chandler office. And if you want to learn more about him or about Ironwood Cancer and Research Centers, you can head to our website.